I propose we start, and in the name of the Novartis Foundation, it's my great pleasure to welcome you to this session on the future of health. How can we, it doesn't work? Okay. In the name of the Novartis Foundation, it's my great pleasure to welcome you to this session on the future of health. How can we unlock the power of data to improve urban population health? And in fact, that's at the core of the mission of the Novartis Foundation, where we use data, analytics, and technology to improve population health and narrow health inequities. Because COVID has been putting the spotlight on existing inequities and gave health inequity a face we can no longer ignore. That's why we have been at the Novartis Foundation, based on our successful cardiovascular population health initiatives in different cities across continents, we have launched AI for Healthy Cities, our new initiative, together with our partners of Microsoft AI for Health, an initiative that aims at using existing data to progress our understanding of what truly drives our health. Because health is not only determined by the health care we can access, it's only a small part of the determining factor. The rest is determined by the way and the conditions in which you are born and grow up and age. In fact, we need to understand those underlying determinants of health much better. And what better opportunity do we have than the fact that we live in a data and digital era, that we can use data and use the massive computational power in our hands and advanced analytics to understand what combination of factors is really driving our health outcomes. And that is the inspiration of this session today, for which it's my great pleasure to introduce the opening speaker, Jörg Reinhardt, who is the chairman of the board of directors of Novartis and also the chairman of the Novartis Foundation. Jörg, please, the floor is yours. Maybe you will also need
Yeah, let's see.
We can sit here together, maybe? Okay.
Does this work?
No, it's fine.
So, Anne, thank you very much for the introduction and for the opportunity to say a few words to introduce this session. I mean, access to healthcare and the growing importance of population health are not only topics which the Novartis Foundation has been concerned with now for decades. These healthcare trends, or these healthcare themes, loom large within our industry and are also gaining increased momentum across the political and economic spectrum. The most recent technological developments in the pharmaceutical industry, ranging from gene therapies to RNA-based medications, have shown that the sector has made huge advances in tackling some of the world's biggest medical challenges. But crises such as the coronavirus pandemic and societal discontent over the lack of equity in some of the most advanced industrialized societies have also revealed major blind spots in the fabric of almost all health systems. Today, these challenges are further aggravated as emerging political shifts risk tearing apart the collaborative socio-political framework that the world has been working on during the past 30 years. As you are all aware, the World Economic Forum's top topic this year revolves around the question how we can cooperate in an increasingly fragmented world. Since the fall of the Berlin Wall, economic, political and societal cooperation has been on the rise. This not only helped mend relations between contending powers, but also created legal and economic networks that proved instrumental in improving the well-being of millions of people worldwide. Poverty has been reduced on a massive scale, while healthcare has seen steady improvements across the board, helping millions of people live longer and healthier lives. Now, the war in Ukraine and the accelerated decoupling from China's economic ecosystem could set the clock back on these achievements and usher in the bleak turning of the times. While such a development is a reason for great concern, it can't be an excuse for inactivity and procrastination on our part, nor should it prompt us to fall into the pessimist trap. As business leaders, we must continually challenge ourselves to work towards improving existing solutions, as well as reminding ourselves that collaboration remains a vital value, which we should hold in high esteem even during these difficult times. The Novartis Foundation, which can look back on a long history of intense engagement in the access to healthcare arena, has nurtured a collaborative mindset ever since its inception. For its nimble beginnings in Africa shortly after the Second World War, to its most recent digital-driven population health initiatives in cities such as New York, the Foundation has been leveraging the know-how of some of the industry's leading experts to create sustainable healthcare solutions. This is an attitude we should continue to cultivate, even as we are faced with challenging political and economic realities. Furthermore, as technology and innovation leaders, we should harness the power of progress to drive new solutions forward. This is especially the case when it comes to the use of data and digital and artificial intelligence in the healthcare space. While digital technologies have become ubiquitous in the pharmaceutical industry when it comes to R&D, the Novartis Foundation, under the leadership of Anne, has developed several programs together with its partners, which showcase the huge impact digital technologies can have in a real-world setting. Of particular note are the efforts in the area of cardiovascular health, to which the Foundation has been committed since 2018. As part of its Cardio for Cities program, which includes a 6-step approach to improve heart health in underserved urban communities, the Foundation has shown that data and digital technologies can be used as tools to strengthen population health. In Sao Paulo, for example, the program helped control rates for high blood pressure patients to triple after just 1 year of implementation, reaching levels that are even better than in many European cities. This, in conclusion, helped avert up to an estimated 13% of strokes. Similar strong results have also been achieved both in Ulaanbaatar and in Dakar. Most recently, as part of its partnership with Microsoft, the Foundation has started the AI for Healthy Cities program in places such as New York and Lisbon, where it is working closely with city officials, academia, and other multi-sector partners. The goal is to use artificial intelligence to analyze available healthcare data and generate insights about the key drivers of cardiovascular population health and equity in urban centers. The idea behind this program is as simple as it is convincing. While only 10 to 20% of our health is determined by the healthcare we access, the remainder hinges on social environment factors such as the place where we were born, where we grow up, live, work, and where we age. These factors can lead to the thorny fact that people who live in the same city can have drastically different life expectancies, depending just on their zip codes. Thus, a child growing up in the Upper East Side of New York City has a life expectancy 11 years longer than a child born to a family living in the Brooklyn neighborhood of Brownsville. Being aware of such discrepancies is one thing. The other is to analyze and develop solutions as to what could be done to improve the healthcare services in such underserved parts of the city. Is it the lack of access to healthy food, a dearth of accessible sports facilities, or simply the lack of education about how to lead a healthy life or prevent diseases? Of course, this is only the beginning of a new program and questions abound. But judging the success of past endeavors and the strong impact we have had as part of the Cardio for Cities program, I'm confident that AI for Healthy Cities will result in a similar success. Likewise, the lessons we can learn from places with high data density such as New York, Lisbon, and Lausanne as well here in Switzerland can later be used to support healthcare system improvement efforts in low-income settings as well. Thus, we at the Foundation could help create a blueprint that could be crucial for controlling cardiovascular disease, which is still the leading cause of mortality, as you all know, in the world with some 18 million deaths each year. Now, ladies and gentlemen, as the world is becoming more fragmented, and while international and cross-industry collaboration tends to face increasingly bigger hurdles, we need to continue working together wherever we can. The challenges are as big as ever, especially in healthcare. But the technological opportunities that we have at our disposal can make a huge difference for populations that so far have been neglected or denied access to state-of-the-art care. While we should aim high in our aspirations, I want us also to remind ourselves that we need to remain humble in our immediate goals and create milestones that are achievable and measurable. This will allow us to make the necessary step-by-step improvements that will prove instrumental when it comes to achieving our ambitious targets. Davos is the right place to discuss this as the WEF brings together high ambition with a deep sense of realism, I hope, by connecting some of the world's key leaders to shed light on some of the most challenging issues of our time. Heart disease and the need for more equitable healthcare systems are two such issues which require our attention to make the world a better and more sustainable place. Thank you very much for your attention.
Thank you very much, Jörg. And with this, I would love to invite our panelists to join me here on stage. Please, you can come all together. Maybe, Honorable Minister, you can sit with me and the two women take place in the center, right? And if you can choose, yes, please. So welcome, everyone. Let me start by a short introduction. So to my left, Honorable Minister Paula Ingabire, who's the Minister of IT and Innovation in Rwanda. Welcome. Thank you for coming, Minister. Peter Piot, who's a special advisor to the President of the European Commission on COVID and a scientific advisor for the European Commission. And Victor Zhao, who's the President of the US National Academies of Medicine. To my right, I have the pleasure to welcome Ricardo Leite, who's the President of UNITE and a Portuguese parliamentarian for health. UNITE is a network of parliamentarians across 90 countries in the world, right, Ricardo? And last but not least, my partner in AI for Healthy Cities, Bill Weeks, who leads Microsoft AI for Health. So this promises to be an interesting and inspiring discussion. As our chairman set the stage, we were inspired by our questions around AI for healthy cities, because we don't want to create data insights by combining data from health and non-health sectors, so health influencing sectors, and then use advanced analytics on those combined data sets. We don't want to use that for research purposes, but for translation into action. We want these insights to then be translated, in fact, in decision tools for policymakers around the world so that they can make better choices where to allocate scarce resources to. What can be the interventions that have the largest impact on the greatest number of people? And we've seen that throughout our initiatives in urban population health in Sao Paulo or Dakar, like Jörg mentioned, that as soon as we use real-time data to drive the decision-making, we get very fast and rapid impactful results. You can really save many lives by the use of real-time data. So I'm very excited to open this discussion, and I may start with you, Peter, as I would like to hear from you. We've seen COVID was like the first epidemic, or pandemic at least, which was completely data-driven. How can we build on that momentum that we can use data for decision-making in many other problems, like in cardiovascular population health? But how do you see that we can leverage that momentum?
Well, thank you, Anne, and also like to commend you on all the work that the Foundation has been doing, and really as an innovative disruptor. And you know, with all the tragedy of the pandemic, which by the way is not over, let's be realistic, there's been a lot of innovation, and I think it's the first time that on such a massive scale data being used. I mean, first of all, collecting the data in real time, analyzing them, mathematical modeling has come to the forefront in terms of advice to policy, but not as an academic exercise, as you say, but also nearly in real time. These people worked very hard. You know, I was then director of the London School of Heights in Tropical Medicine. We had about 100 modelers working 7 days a week and providing input. And that was the beginning. And then afterwards, it was also to develop models, what would work, what's the impact, and the feedback also from the field. All that was in essence, there was nothing new, but the fact that it was used at scale and for policy directly, that's what I think was made a difference. And what was key were a few things. Of course, it all starts with the quality of the basic data. And that's something, frankly, where we need to invest more, I would say. And that's, we see it across all countries. Two is, is actually transparency. Also, that it's clear where the data are coming from and so on, because we'll come back to that in terms of trust. Three is having the, the openness across borders, because it's not, this was a pandemic, obviously, but sharing these data was important. And it happened more than ever. When I compare to 2003 SARS, where the data were not shared, and this was both in terms of public health and in terms of research. And we've seen the impact, partly in terms of the ability to develop new vaccines, therapies. That, of course, is always driven by data, but the fact that it was possible to do, but then also real-world evidence. Do these vaccines work in the real world? So all that has happened. And I think that I hope now there's an infrastructure that was built and that can then be used for all the rest. And that's where we need to bring together the, let's say, pandemic preparedness. There's money invested in it. I hope it will continue. But connecting that with all the other issues that you raised and that you raised for in terms of health. That's the opportunity. Otherwise, I think we're not doing our job if we just keep it for pandemic preparedness. But we need to connect it.
Thank you so much. Very important, Peter. It's absolutely for all health problems important. Victor, the US National Academies of Medicine have done a ton of research on health inequities and how intersectoral collaboration is part of the solution to address those also in cardiovascular health. So why do you see it's urgent for governments to forge such intersectoral partnerships that can use data and technology to advance population health?
Thank you, Anne. Is this on? Yes. First, let me thank you for putting this panel together. It's a really important topic. And thank Novartis for taking leadership in this area. Let me just first respond to what Peter said, which is so true in COVID. I think if you look at even our country, we're not collecting data properly. So it's not just sharing data. It's a lack of collection of data. Until we begin to realize and we collect the data, we understand some populations are more risk than others, and even subpopulations of different ratio and other different risks. So I think getting the information is critically important for looking at equity at risk and others. Now in cardiovascular, this is a real urgency. As you know, I've been working in cardiovascular all my life. And you know, when you think about where we are today, we're not really getting any better. If you look at the numbers, right? I mean, we have such great therapeutics and diagnostics, and yet, if you look at the global numbers, diabetes, in many populations, more than 10%. In some populations, 15% of population diabetes. Hypertension, area I'm interested in, 1.6 billion people globally. And many of them, of course, are low and middle income countries. And obesity, you know, I guess you can say that about 50% of the world's population are overweight, and obese, of course, yes, about 20-some%. I think we have a lot of work to do. So what's the problem? Okay, so I think Framingham was really important in identifying risk factors. So it really had made a big difference. But the question is, first of all, even we know the risk factors, how do you detect them? How do you find them? I work in blood pressure, and I can say, if you take a blood pressure cuff, have a patient come to your clinic and measure it, you're never going to do the early detection. So technology becomes really, really important, right? What are the new technology, digital technology, photoplethysmography, and others that can say, I can measure my blood pressure at home, and in fact, easy to measure, is linked digitally to care data, and so that I think is critically important, right? So I think the importance of early detection and prevention. But I think we also really need to think about population at risk. Not all population at risk the same way. I think you mentioned this. If you look at zip codes in our country, you know, in zip codes, we have 15 years of life expectancy differences. And I think globally, it can be as many as 30 years between Japan and some countries in Africa. So I think that when you started looking at, as you say, urban population, you do need to look at what population are at greater risk and what subpopulation are at greater risk. So that's where data makes a difference. And then, of course, we need to think about going upstream. We all know, as Chairman Reinhardt talked about, social determinants, factors that influence people's health. You mentioned this, right? 10% is healthcare, 90% is all the other factors, socioeconomic, behavioral factors. So I guess we need that information to make a difference. I believe this is where digital technology, Peter's point, being able to collect that information in the population. I believe this is where population health matters, because it's not just care, but coming together of community and populations. And I also believe that that's where AI can make a difference, because you can apply AI to look at population risk, mapping risk factors, people who have socioeconomic factors to appear at greater risk, and begin create a map. And when I was at Duke, we used geospatial mapping, because in Durham, North Carolina, we care for about 90% population. So we know all the people's information. If you combine that with social data, et cetera, we can map where the food is. In terms of pregnancy, we look at where access to clinic is. All that stuff, I think, can make a huge difference. So cardiovascular, the number one leading cause of death, morbidity, mortality, a lot of work to do. I think still we need to apply these things, these possibilities, this innovation to solve the problem.
Thank you so much, Victor. That's exactly at the core of what we are aiming to do with AI for Healthy Cities. And I cannot agree more that early detection of the risk is absolutely the key to better cardiovascular population health, because many people around the world have high blood pressure or high cholesterol without even knowing. Yeah. And we know that cardiovascular disease after COVID is even on the rise. In the US, it's projected to disproportionately rise in the racial and ethnic minority groups, unfortunately. So thank you for making that point very much. Ricardo, if I may turn to you, as a global advocate for science-based, data-based policy making, what do you think we need to do different? What is working well, and where is it urgent to change things?
Well, thank you, Anne, and I'd like to greet my colleagues. It's an honor to be here among so many friends, and I congratulate you also, following Victor's words, on bringing this important topic front and center. And to answer your question, you mentioned that I run an organization called Unite. It's a network of parliamentarians for global health. We are in 90 countries. And what we have seen everywhere is that we have a misconception of what we call health systems. At the end of the day, we have disease systems. We have systems that have been built and have incentives embedded within them that actually drive more disease. And we have to break the cycle. The more sick people we get, the more money we're putting into the system, in this vicious cycle that is getting worse with the rise of poverty and inequalities. And as we know, poverty is the main driver of disease. So we have to get away from that industrialized model towards a model that is focused more on health outcomes. And so we can lower the burden of disease and refocus on increasing quality of life and well-being. That being said, then, why aren't politicians doing this? I think we are facing a crisis of vision, or lack of vision, if I may say. If you ask healthcare workers in most health systems around the world, and you ask them, what is the vision for the Minister of Health in your country for 10 years from now? You will never get the same answer twice, because nobody knows. We're all in survival mode, especially after COVID. We need to know where we want to go, or else we'll never get there. And so as soon as we know where we want to go, then we can start saying, okay, then what is the data we need to collect? How can we fix the data collection process? And I fully agree. How do we start collecting that data? Because without collecting structured, contrasting data, we won't be able to then fulfill the full potential of artificial intelligence, of blockchain, of augmented reality, of Internet of Things, of all of these amazing technologies that will just be theory if we do not make them into practice, and you cannot make them into practice without data. Data is the electricity of the 21st century. And we know that the health status of our citizens depends 60% on everything that is non-clinical. It depends on community factors, environmental factors, economic factors, behavioral factors. And so we need to address all of these determinants of health to make sure that we fix the health systems and we address the data issues accordingly, which means that we can't do this alone. Governments or payers have to work with industries, but these two cannot solve the problem also alone. We need to involve all the different elements in the government spectrum. The idea of health in all policies has to go from theory into practice. We need civil society. Health for all will only be a reality if we make sure that those that live in most vulnerable situations are included, or else they'll continue in the margins. And with the digital divide that exists in societies, those that are in most vulnerable situations will also be forgotten. So we need to fix this alignment of vision and getting politicians on board. And so I'd say, how do you fix that alignment? How do you get those politicians on board? And if I can have just 2 more minutes more to say what we've come up with, the 5 rules of thumb to get that. And it's the A, B, C, D, E. You're in Davos. You're all very smart. You'll remember this in the future. So A is awareness. You need to make sure that whatever change you're fighting for is in line with the constituency of your politicians. If it's not in line, it won't happen. B, budget sensitivity. Make sure you show where the money is coming from to pay for the innovation or change you're pushing for, or else it will not happen. You have to have a key-in-hand solution. C is cost opportunity. Making sure that you're not showing only what you're going to achieve with the idea you're pushing for, but actually what is the cost of inaction? What will happen if you do not do the change you're pushing for? What will happen to the people you are serving? D is data. Before and after data, showing that data, so that you can also discuss the sunk cost fallacy. The fact that you are probably investing a lot of money in things that do not work, but people do not want to go away because they've invested so much. Having the courage to change is really hard. And E is something very dear to politicians, elections. and elections are extremely important because the electoral cycle is so short. And the lifespan for ministers of health is even shorter most of the time. And so we need to present solutions that are actually timely. We show outcomes for those 2 years, those 4 years. And may I say, in the industrial corporate world, CEO lifespan is also getting shorter. The CEO average span in their job is 4 years in companies nowadays. So company executives also want to show results. So we need to align everyone so that we can actually achieve the impact of going from disease to focusing on health promotion across the board. Thank you.
Thank you. Yes, this deserves an applause. Thank you, Ricardo. Very important points. And the cost of inaction, I really make that point thanks to your intervention there before. Minister Paula, if I may turn to you, Rwanda has been a trailblazer in the use of innovation and technology throughout your country, but also throughout your health system. Can you give us some examples of how you use technology to improve population health in Rwanda, and also maybe explain how the great intersectoral collaboration you have in Rwanda between your ministry and the Ministry of Health is so key to that success, and what helped to make that work?
Thank you. I think it's a tough act to follow. But on one hand, I'm also grateful I'm not Minister of Health, so. But just to go back to your question, and I think as I was reflecting on the topic that we're discussing this afternoon, I think the examples I share are more or less, we are not just focused on urban healthcare, especially because as a country we don't have that luxury to decide how do we exacerbate further the inequalities that come with the use of technology in different sectors. And so the examples I'll share shortly will really look at how we continue to leverage different technological solutions and data to really democratize access to healthcare. And I think for many of you in the room, you perhaps have already, if you've researched Rwanda and healthcare, you probably already know about Zipline, which will be the very first story that I talk about, which really was around how we use drones to provide access to medical products to healthcare facilities across the country. And so for us, as a proof of concept country, what this meant was, on one hand, we had a problem of logistics. How do we reach all the healthcare facilities? We can't build, the cost of building, cold room infrastructure facilities in every healthcare facility was too high. But at the same time, you want to ensure that the access to quality healthcare in rural parts of the country is similar to what you can get in the urban parts of the country. And you had Zipline on one hand, who had an untested technology, but that had its promises. And so we could have chosen to be in a wait and see mode, which we didn't, or to just, take a big bet on this is what the technology can provide. And many times as policymakers, just to echo some of the thoughts that have been shared, is we can't regulate what we don't know. And so what that really means is that we also must be open to really moving as fast as the different technological innovations that we have. And so if you ask me, how did we use data to improve healthcare for this particular example? One, we've used the data to understand how we can deliver much faster and more efficiently medical products to these health facilities. And so starting with being able to transport these medical products 3 hours, 3.5 hours on average, and being able to deliver medical products within 13 minutes, I think, and just really looking at how you can constantly improve that process so that you can deliver these medical products in a much shorter time. And the results are very interesting, because what we've seen with a study that has been conducted is that you have at least a reduction of 88% of maternal deaths. Then the other thing you're seeing is a significant reduction of 0.03% blood wastage, because blood products were one of those where, because of the expiry dates and everything, we had a lot of blood that was being wasted. But because we were able to have this on-demand supply for medical products, then we were able to also reduce on the wastage. And so today, really, these are some of the examples we continue to see, with over 75% of the population that is being served, but also using that data to see how we can improve healthcare logistics. The other example I would like to share is around AI chatbots, and we did talk about Peter talked about the pandemic. What we had to do very quickly was to figure out how do we make sure that with all the false information that is going around about the pandemic and creating panic and fear among the population, what's the easiest way that we can get people to have access to real information, to accurate information, and have one single source of truth? And also bearing in mind that majority of our population, like many of the developing countries, had feature phones. So we had to figure out what's the best way with a feature phone that someone can get access to credible information, so that this misinformation that is going around can reduce the panic that we see and people really making some of the wrong decisions. But we've also looked at how do we have about 86% of our population with phones, but 80% of those are people who have basic phones. And even as we think about the distances that one has to travel to seek medical health care, we had to figure out what's the best way that someone can just prompt a doctor with just an SMS, and the doctor will call directly, and then they can be provided with a much needed healthcare intervention without necessarily having to travel long distances. You only have to do that if you must, and many times because we have all the community health workers in place, then they should be able to go to the different homes and provide the much needed intervention. The last example that I wanted to share is an example of a Rwandan startup that was able to use AI models really for radiology. And what we're looking at is really a ratio of 1 radiologist for 1 million population in Rwanda. So looking at that, it almost means that it doesn't matter. You have only 13 radiologists in a country. How do you make sure that the most urgent cases are dealt with in real time? Because they'll have a whole backlog of cases to look at, but they'll never know, if I have 10,000 files, which one of these is the most urgent and how do I deal with it? And it takes me back to your point around public-private partnerships, because yes, government may be great at putting in place the policies, ensuring standards, but then you have all these startups that are building amazing products and solutions. You have all these bigger companies that are also, doing some R&D in the different healthcare space. So how do we bring that together and enable for a rapid deployment of that? And I'll come back to the very last part of your question, which is what are the foundations? I think everyone on this panel talked about data being a solid foundation. Collection is one thing, but also the ability to share this data. Whether it's building those, data protection and privacy laws that are really needed as a critical foundation to how data gets to be shared, but also how you get to process and use this data in ways that can improve population health outcomes. And the final one, of course, is around computing infrastructure. I think that's really one of some of the foundations that we need to invest in collectively as the industry, as the government, because again, at the end of the day, no one single stakeholder is going to be able to do it on their own.
Absolutely. Very important, the need to work together and really share, but having the infrastructure to be able to do that is crucial indeed. So Bill, that brings me to you. In fact, why are we doing this work now? What did you see in the US? You've been on quite some research on the differences in economic conditions, the relationships that you found between the disparities economically and the health outcomes recently in the US.
Yeah, so Bill Weeks, again, thanks Anne and Novartis Foundation for convening this panel. Really interesting discussion, and thanks for having me here. So why now? I think why now is because we are beginning to collect data that are relevant, and we have the compute power to actually integrate the data and make sense of it from a multiplicity of streams, all having to do with the social determinants of health, which we've heard really do kind of modify health and determine health in zip code areas. The differences that I've found in the studies I've done are associated with economic disparities in local areas. So zip code level economic disparities are, when people are in low prosperous counties or zip codes, their lifespan is shorter. They spend more on healthcare, actually, in the Medicare population. They have lower quality care, and they spend a lot more time in the hospital, and particularly in avoidable hospitalizations. So we're wasting a lot of money on things that don't work, and they have a higher mortality rate as well. The intriguing thing as an economist is to look at what happens when there are natural experiments, which is another reason to have these data. Because if you have timely, ongoing data collection, you can look at what happens when things change, and that can give you insights as to policies, particularly things that are modifiable. I mean, one of the challenges is, of course, that you can't really change the demographics of a zip code in a very rapid way, right? And demographics do matter, right? With the thing we learned with COVID, your biggest risk is age, right? We can't change some things, but we can change economic conditions locally by having economic opportunity zones and things like that. So what we found is that among the Medicare population in the U.S., it's an older population, when zip code level economic opportunities changed somewhat, when the zip codes became more prosperous over a 15-year period, the annual mortality rate dropped considerably. In fact, dropped to the level of the most highly prosperous zip codes. So you see that things are changeable, and it wasn't all just gentrification and people moving in, which is a concern that one might have, right? It's actual seemingly changes in the quality of care that's being delivered, and the type of care that's being delivered, and even the cost of care being delivered. So I think that the key thing is that should we, particularly for politicians, we need to think about modifiable things that they can achieve in a short time period, which for me are fairly economically based, right? Where we can have investments, and what we need to do critically is measure the externalities or the returns on those investments in different terms than just financial ones, but also in health, right? To think about what are the health gains that we get with these investments, and how can we in particular focus on the most vulnerable to decrease those gaps in health disparities by economic investment.
Really important, but showing you how complex it is as well. So Victor, maybe a very short follow-up question. You've been long promoting equity in access, and how do you see specifically the role of public-private partnerships that are enabled by data and technology to help us there and improve population health or healthy longevity?
And may I first of all say that I strongly agree with all my fellow panelists on many issues. Ricardo, the E can also be equity. And I thought that's what you're going to say. So I can see how, I think election is important. We just went through that in the United States. But at the end of the day, I think the equity issue is the key issue, right? I mean, we already talked about the huge disparities in populations, zip codes, and geographic distribution. And I think it's very clear that we need to be sure that opportunity is afforded to everyone. A couple of other things. I'd like to also define what population health is. Actually, National Academy was the first to use that term, population health, 2013. And in fact, at the time, public health was seen as surveillance, emergencies, etc., some prevention. Healthcare is looking at disease and treatment. And we're missing a huge gap, which is the outcomes of population. But truthfully, when data look at this, it's not only entire population, but individuals as well. Tremendous opportunity. So this is where the multi-sectoral issue is. Because as been said, one important area is that how do you actually reach the patients? I know that everyone's talking about the G7, universal health coverage, primary care. Truth of the matter is that we just don't have enough physicians and nurses to do all that stuff. In fact, it's very clearly said by a few people with COVID, we're having a shortage of healthcare workers. I think this is where community health workers are important. And the minister, I think, pointed that out very effectively, right? Not the traditional way that you go see a clinic or someone going out to see nurses, doctors, but community health. But that's where data becomes extremely important. The public-private partnership is the whole issue of enabling data-driven community healthcare, right? That is, community workers go to community. They may not have an MD or RN degree, but they're able to do the initial screening, etc., and use that data-driven approach. And also using, this is where I think resources from industry is so important. For example, I see Rachika here, and Medtronic, the SPICE program, I think it's in Rwanda as well, right? That use, in fact, a digital platform so that healthcare workers can be there taking information, but connected to public health, connected to clinics, and being able to actually co-manage the patient. So I think that, in fact, is a really important area. So coming back, when I look at Microsoft, Novartis, Medtronic, many others, I think the importance of public-private partnership is it. When it comes down to community health, it's actually, public health is actually all these sectors. Public health, healthcare delivery, social care, community care, and all the pieces. I wrote a paper in Lancet to say population health should be convergent science and practice. Convergent science is beyond multidisciplinary science. It's bringing together sectors together to solve a problem, focus. And so we think about population health, it's a whole discipline in research science itself to bring together social behavioral scientists, economists, health people, but also engineers, urban planning, law, and many others. I think that, to me, is emerging as a major area of development. And this is where I think public-private partnership can really help us use the resources and your network together.
So key, and we have seen that throughout our work in the Novartis Foundation as well. As long as the initiatives for population health are locally owned, we reach success. That's a condition sine qua non to even start an initiative for us. So very important point, thank you. Ricardo, as a decision maker, how do you determine what kind of data insights you will use? Or what kind of data insights do you think you need to be delivered to you?
Well, I guess that it's very important to start with the outcome, to know where you want to go, as I mentioned before. And I think scientists, those that actually produce recommendations for politicians, also need to adapt the way results are communicated. And this is a challenge for everyone across the board to make sure that whatever, basic science and then translational science is only useful then if it can be used in the real world. And this kind of transformation on science communication, and I think the pandemic was a very strong demonstration of its need to evolve towards being even more effective so that politicians actually get the insights that they need in terms of knowing what data to look at and then to drive their decision-making process based on that data. I'm a physician by training, but I've been in politics for some time, and I also had a role at a city level as a deputy mayor and councillor. And what we did, we were talking about zip codes. We got a protocol with the ministries of health, social security, and education, and we got all the data that they had available for our city at the zip code level, and we geo-referenced it on a map, which allowed us to cross that data, discuss with experts, to understand certain phenomena. It doesn't give you immediate answers of what to do, but it allows you to start asking the right questions and start assessing the impact of your policies. And basic things like, where do we start building a bike lane? Why don't you start where you have highest childhood obesity prevalence in your own city? So there are basic approaches you can make. Or, for example, also talking about the usage of data, there's a very interesting example from Portugal, which is in our primary healthcare clinics, where our primary healthcare clinics, we have this real-world experiment ongoing where we have 3 types of clinics. One, which we call classical clinics, where doctors and nurses get a pay no matter what they do. A second type, where we measure outcomes that have been previously agreed upon. And the third kind, where we have those outcomes being measured, and we actually create incentives if results are achieved. Well, what happens is, when it comes, for example, we're talking about cardiovascular disease, hypertensive patients that are controlled with controlled hypertension, only 30% are controlled in the classical model, where people are paid no matter what they do. That goes up to 60% when you start measuring, and it goes up to almost 90% of controlled hypertensive patients when you create a financial incentive. So when people tell me measuring outcomes and incentives don't matter, I just show them that graph.
That's impressive indeed, well, 90%. But to build on that, Peter, throughout our society, on the point of transforming this science communication, throughout our society during COVID, we really saw a growing mistrust for politicians, for institutions alike. How do you see that was most important, what we can do now to make people trust data and trust the decisions that are made based on those data? And how do you see that is also a challenge to then apply to other settings where data may not be available?
Yeah, I think this is a really important question that was highlighted by COVID. I mean, it has always been there, but it's a combination of COVID and also our ever more polarized world, at least in some societies. It depends on the society also. And with COVID, some of it where I think the lack of trust is, I actually think is legitimate, then you ask questions. We should not discourage that. And when you have a new vaccine and people ask, okay, is it safe and so, I think that's totally normal, and we should, and that can be addressed by better information. But there's a lot that is not so spontaneous. Some of it is driven by ideology, some of it even by foreign powers. We should not be naive about that. For me, trust has become also a security issue in the classic sense of the word. So that's maybe for another panel. But, as you know, my wife Heidi Larsson, she deals, that's full time, so at home I hear a lot about it. But then, it's very different. Last week I was in Singapore, and there, a meeting like this, everybody would wear a mask. Even, I go jogging and cycling, and people wear a mask, and the government has said, well, there's no need to wear a mask when you go outside. So there are cultural issues about trust and so in societies. And I'm very intrigued by Portugal. You have the highest vaccination rate for COVID in the whole of Europe and in the fastest time, without making a lot of fuss about it. So I like to hear the study, the trust, and not only the mechanics of it. Now, data are key also. There's a lack of, people can get paranoid, 1984, Brave New World, but data being used to control me and so on, and that is driving a lot of what you see in social media. And I think that there's no magic solution for that. I was interested in what the minister was saying, how you're dealing with misinformation in Rwanda. But we have to take some structural measures, and in Europe, I would say the health, the European health data space, I think is going to be very important. We are very strong. We have strong legislation protecting people, privacy, and so on. But sometimes that's also a handicap for clinical trials, for research, and all that. On the other hand, if we would say we're going to abolish that, that would increase the paranoia even more. And so with the European health data science is really trying to bring in accountable governance of use of data in the health space. And let's not forget, the EU is not a sovereign state. I mean, it's 27 member states with different health systems, different cultures, different ways of managing data, the governance of data, privacy laws, and so on. And so having a common system, I think, is important, but that's not going to solve the trust issue. But it means also that we need to do, I would say, take this on in a systematic way. We need to do the science, what is about this trust, and quantify it and understand it and accept that that's a part of life. And secondly, we need to invest in it, and that we shouldn't start any program without communication. And that is something where politicians are very important. I'm one of the people who don't think that politicians are useless. We need the best people in the world now to lead our country. In the case of Respublica. So I think there are ways of dealing with it, but it's not easy. And also, as I said, the current polarization driven by algorithms in social media and so on, that is something we need to address. I'm not saying we should, throw it away. So I think that is probably one of the big lessons from COVID, and that we have to follow up on how to manage that, and not in an amateuristic way, as we often do in public health, and in health, just by you should not do this or that. That doesn't work. Okay. People are fed up with that.
Thank you. Yes.
Yeah, first of all, I totally agree with Peter. The issue of mistrust is a big problem. I think the science of communication really has to be developed more thoroughly. Most of us don't see communication as science, but I think there's a whole science of communication going forward. So, for example, I think scientists and physicians and healthcare workers sometimes feel if they tell the facts, people are just simply going to believe it. And certainly we have to learn, in fact, how to speak the language. So I think it gets down to communities, that actually you develop trust in the community through understanding what their needs are, what their fears are, having community leaders to be the spokesperson to help scientists connect. Also, scientists have to really be transparent. Frequently, we don't know all the answers. And so we come across too dogmatic at the very beginning to say, you should do this, only to find later on the scientific data says you don't have to. And that creates mistrust. So I think very early you have to say what we do know, what we don't know. And then I think finally, the social media have a responsibility, right? They really have to be able to look at what's factual, what's not. At the Academy, we've worked with YouTube, actually, on an initiative which is now adopted by WHO and others, looking at what are those kind of reliable sources of information. So YouTube is willing now to label some of the videos to say, this comes from NIH, and therefore it's reliable, this comes from this. I think it's a starting point, right? And I know that there are organizations like the American Board of Internal Medicine that's saying that if our members, as code of conduct, post misinformation, their membership will be looked at very carefully. So I think accountability is another issue.
Thank you for strengthening that point, and it makes it even clearer how Rwanda started with the right way to make sure that the population gets the right information. But Minister Paula, you also stressed the power of local innovations that are really massively important, and especially in Africa, I think. We are big believers of that, you know. But how could we create a more sustainable, scalable approach to get approvals for these innovative solutions also within the public health system? We are working together with you, the Ministry of Health in Rwanda, and our Health Tech Hub in Kigali to build that blueprint, policy blueprint for fast-tracking health tech innovations in the public health systems, which is going to be an example for every African country in the end. What do you think are the main foundations for that?
Thanks, and I think you touched on it. First, for us, it's always about understanding what are those health priorities we are solving for. So it's not just a question of you're just going to deploy technology for the sake of deploying technology. It's what are you really trying to solve for? And when we started this collaboration with Novartis, the Ministry of Health, the Ministry of Technology, and the different startups, the idea is to say, what are those problem statements that we are trying to solve for? And once you put them out there, then you even provide better data and better context for these innovators and startups to understand that they are actually creating value, as opposed to let them build 100 of solutions. I'll try and figure out which one will respond to what I'm looking for. And so for us, that was critical because, like any other government, you're constrained on both financial and technical resources. So if you wait for people to just deploy and you try to customize at the end, I think there's that, the learning curve is too steep. And so that was really the starting point of our collaboration with Novartis and the different institutions across the board. The second thing was for us to put in place a framework which we've called public procurement for innovation. Because as you can understand, when it comes to public procurement policies, a lot of it is more focused on tested and tried solutions. But when you talk about health innovations, a lot of them are not tested and tried anywhere. And so we had to sort of create a caveat or a section within our public procurement policy or law that allows us to procure new to the world innovations without us looking for experience or, where have you tested and tried it, and then allowing that when these innovators deploy these solutions, we are learning with them and we are perfecting the solution as we go along, because that's what's really important, as opposed to waiting for, can you test it elsewhere, and once it's proven successful, come back to us. Again, it comes back to our vision of being a proof of concept hub where we can test and try some of these solutions. The other bit, which also anchors around the policy that we're creating with you, is that in our own context, we had a very siloed process where a health tech company will not know what kind of licensing has to happen. Who licenses what? If it's a hardware, if it's software, is it the health industry? And so we had to make sure at least we try and streamline that effort so that it's almost like a one-stop center. They come in, they understand these are the requirements, and then from a government perspective, and if we have 4 or 5 institutions behind that have to look at, one is looking at the data sharing aspects, the other one is looking at the hardware, the other is software, the health outcomes, at least we're doing it jointly and making sure that people don't spend a whole year trying to figure out how they become certified, but rather we spend more time in testing and trying that solution.
And this is a fantastic end point of our discussion. Unfortunately, our time is up, but I believe starting with the right problem statement is really what we have to do in all aspects of health, but specifically in population health. And we did get to the right problem statement. Thank you, Victor, for that. And let's create together what it means precision population health and use the data and the advanced analytics we have at our hands to do better in the future. So I want to, with this, to thank you all for your participation. Unfortunately, it's too short to take more questions, but I really enjoyed the conversation. And a big applause for our fantastic panelists, please. Thank you so much.